Yes, sir, you can
Please
start.
go ahead. Yeah.
Thank you. Good evening, ladies and gentlemen. A very warm welcome to another exciting episode 6 of Secrets of Neurology, Clinical Pearls coupled with recent therapeutic advances. Normally, it is held in the last Friday of every month. This time, because of Xmas, it has been shifted to today. I begin by wishing each one of you Merry Christmas and a happy and prosperous New Year. A very warm welcome to our patrons, our program director, Professor Dr. Sudhir Shah and Dr. Lakshmi Narsimhan. They have been the brain behind this entire show. And very warm welcome to all the experts and faculties from prestigious Nimmans Institute. As known to all of you, normally the program is scheduled for another exciting 1.5 hours, and we would try to close it by 9:30. My privilege and honor to introduce the two program directors. To begin with, Professor Dr. Sudhir Shah, Professor and Head of Department, NHL MMC, SVP IMSF, Ahmedabad, Director of Neuroscience, Sterling Hospital, Ahmedabad. Sir is Professor and HOD, Director of Neuroscience, Sterling Hospital, Ahmedabad, and also Consultant Neurologist to His Excellency, the Governor of Gujarat. Many awards and accolades to Sir's credit. Author of 6 books on neurology, many journals and peer-reviewed publications. Because of his contribution to patients, society at large, Government of India conferred the prestigious Padam Shri. He is also a recipient of prestigious Dr. B.C. Roy Award and UNO Award. We have learned from his lectures and his interactions on BBC, CNBC. Professor Sudhir Shah's interest is primarily into stroke, neurodegenerative disease, and epilepsy. So thank you for all that you're doing in the field of neurology and for all the DM and DNB students. Our second program director, Dr. Lakshmi Narsimhan Ranganathan. Sir is Director and Professor, Institute of Neurology at Madras Medical College, Chennai. Many awards and achievements to Sir's credit. Paltussi Advisor from AN, A.B. Baker's Award as Global Best Teacher, Best Paper Award at American Academy of Neurology, Global Elsevier Atlas Award, Executive Committee Member of World Federation of Neurology, 3-term Executive Member of Indian Academy of Neurology, CME Convener, Indian Academy of Neurology. And for all the DM and DNB students, you'll be happy to know that consecutively 7 years, he organized academic activity from 2010 to 2017. Both the two program directors have immense contribution to the field of neurology and for all of us. Over to you, sir.
Thank you very much. Thank you very much, Manoj Bhai, for that kind words of introduction. Dear seniors, colleagues, and friends, first of all, most welcome for this wonderful series of program. Today is the 6th in the series. And also, Merry Christmas to all of you. We pray and wish that the new year, that is 2021, brings a lot of good hopes, new, better things, and improved standard of living, thinking, and communicating. I wish all you good health and safe life. Okay. With that, I would like to tell a few words about this program, those who are new for the day. This is the continuing series of medical education. It is focused on secrets of neurology, which will look into the pulse of neurology, clinical pulse, as well as the localization aspects, and then a lot of clinical material being discussed here. So clinical with therapeutic advances and so on. So under that pretext, we are having this 6th program. And as Dr. Manoj Kumar mentioned, we do it usually on the last Friday of every month at this time, 8 p.m. But for the first time, due to Christmas, we have shifted to today, there is one day later. Again, next month, we'll have only on last Friday of the month. I must first congratulate and thank my co-director, Dr. Lakshmi Narasimhan, for his excellent input for the program. And that's how we have designed a wonderful program for you. At the outset, I would also like to thank INTAS, Mr. Chadda and his team for providing this platform and being so committed for the educational purpose. May I have the first slide, please? I would like to introduce today's speakers. As you know, the program, today's case discussion is from NIMHANS, Bangalore, and I especially thank Dr. Ravi Yadav and his team for making this possible. As per the program curriculum, the first part, the history part will be presented by senior resident from NIMHANS, Dr. Muhammad Samim Mondal. Next slide, please. Next slide, please. The next slide.
Sir, it is next slide, sir. Dr. Abhishek Goel, sir.
Oh, okay. So Abhishek is the another senior resident who would discuss some of the localization and some intricacies of the case. And based on the clinical history and examination, they would try to localize. Next slide, please. Then Associate Professor Dr. Nitish Kamble from the Department of Neurology, NIMHANS, would give some of the clinical pulse and give further insights to the case. It is a pleasure to introduce Dr. Nitish Kamble, who is MBBS, MD, and DMDM from the same NIMHANS Institute. He has received the Postgraduate Resident Award in Neurology. His current affiliation is that he's an Associate Professor of Neurology, has been mentioned. And his areas of interest are Parkinson's disease, Huntington disease, atypical Parkinson, psychogenic movement disorders, along with application of transcranial magnetic stimulation, electrophysiology of movement disorders, etc. And he is specialized in botulinum toxin injection. He has many national, international publications. So he will give us the clinical pulse of this case. Next slide, please. And Professor Ravi Yadav, he would give the final remarks and take the case very much in detail further. As we know him very well, he is a Parkinson disorder and movement disorder specialist. He runs the clinic for that in NIMHANS. He was a past treasurer and founding member of Movement Disorder Society of India. He has also a lot of interest in spinocerebellar ataxias, PSP, and non-motor symptoms, etc. And he has been interested in the functional neurosurgery program also. He has, to his credit, more than 125 publications in index journals in the movement disorder and in national and international journals. He He was awarded the Best Postgraduate Award in Neurology in 2008 at New Delhi, while he was doing MD. Established Movement Disorder Clinic in NIMHANS, and he has initiated the postdoc fellowship program in movement disorders in NIMHANS. He is further organizing secretary of MDSICON 2017. As we know, it was a very successful program. So with those words, I welcome all of you again, and I particularly thank Dr. Ravi Yadav and his team for taking up today's case. And once again, thank my co-course director, Professor Lakshmi Narasimhan. Thank you very much. Enjoy the session. Dr. Yadav, all for yours.
Right. So I welcome everyone for this exciting session of case of neurology, and I thank Dr. Sudhir Shah and Dr. Lakshmi for giving us the opportunity to present our case. So we have actually chosen a case which is we are trying to evaluate a slightly out of the box type of scenario, because the part of neurootology slightly is not discussed many times, as we consider the opinion from other experts in the field. But what we are supposed to know and what are the challenges in this type of cases is what we will discuss today. So our senior resident, Dr. Shamim, will start with. He will present the history. Then our final year resident, Dr. Abhishek, will try to localize and give a structural evaluation of the case. And then subsequently, after that, we'll again go back to the examination and see if any other points are added in after the his assessment, and further do we have opportunity to further narrow down the options. And then Dr. Nitish will further take it from there, and then I will also pitch in between to tell about the various aspects and approaches. So let us start. Dr. Shamim, you can start. You are not audible. Shamim, unmute yourself.
Am I audible, sir?
Yeah, please start.
Good evening, my respected teachers and my dear colleague. Today's case presentation, curious case of hearing loss and imbalance. Informant is patient and her daughters. All are reliable. Miss S, 42-year-old lady, presented with complaints of decreased hearing for 25 years, weakness of both lower limbs for 10 years, imbalance while sitting for 9 years, difficulty in swallowing and change in voice for 5 months, weakness of upper limb for 5 months, and a worsening of lower limb weakness for 5 months. So, in a nutshell, decreased hearing started at the age of 17 years. Then weakness of both lower limbs started at the age of 32 years. Then imbalance. Then at present, 42 years of age, swallowing difficulty, change in voice, and upper limb weakness. This 42-year-old lady, educated till 10th standard, homemaker, was apparently asymptomatic till 17 years of age, when she started to experience decrease in hearing in the form that she started to ask people to repeat again. And initially, she used to bring the ear towards the speaker and frequently try to read the lip movement of a speaker while in conversation. While replying, she used to raise her voice than that of the speaker. She could hear better at home, but hearing was difficult when she went to market. She used to hear her daughter's voice better than the voice of her husband's. She could hear the barking dog, tapping sound of water in comparison to birds chirping or sounds of motorbike engine. She could hear sound but felt that sounds were muffled and not able to understand what the speaker was telling. Similar symptoms were in both the ears. This was not associated with any ringing in ear or heaviness inside her ears or ear pain, itching, irritation or ear discharge or any dizziness symptoms. At present, her daughters speak close to her ears, whispering or gesturing, and she replies in louder than usual conversation voice. Since 10 years, she developed insidious onset, gradually progressive difficulty in walking in the form that she used to walk by dragging of her right lower limb, associated with a sense of stiffness, due to which she was unable to fold her right leg while walking, and with history of tripping and fall over uneven surfaces. With no history of lifting the feet unusually high, no tremulousness in lower limbs while stepping, no history suggestive of crossing one leg with another while stepping, or any history suggestive of any circumduction. This progressed for over 6 months and was followed by a similar complaint in left lower limb also. During this time, she had imbalance while walking, which used to worsen in dark and while walking in narrow passages. And there is history of slippage of footwear without her knowledge. She could not perceive the texture of the floor on which she was walking upon and felt as if she was walking on a pile of cotton. It worsened on closing the eyes. She felt unsteady while splashing water on her face. The patient reports that the weakness was static for almost 9 to 10 years, and during this time, she would ambulate with one or one person support. Since 6 months, she is experiencing drooling of saliva from the corner of mouth on either side, and also history of food getting stuck in the back of oral cavity. Since then, she has started to have swallowing difficulty. She could chew, but during swallowing, having difficulties, more to liquids than solids, associated with choking episodes and nasal regurgitation. Her eyes used to remain open during sleep, noticed by her daughter, and soap while bathing, soap used to frequently get into her eyes. In next 1 to 2 days, she started to have change in voice in the form of effortful speech with words running into one another, and family members feel her voice is hoarse. However, patient's comprehension was intact. Over the next 2 days, she noticed upper limb weakness in the form of difficulty holding objects, buttoning, unbuttoning, tearing chapati, mixing food, and combing her hair, getting things from overhead shelf, pouring water on head while bathing were relatively easy. The patient had difficulty holding onto objects in the dark, and she felt her fingers used to tremble when lights were switched off. She noticed worsening of lower limb symptoms in the form that she was completely unable to walk or stand with support and was bedridden. Regarding negative histories, no history of tingling paresthesias or Barber chair phenomena, no visual symptoms, no bladder bowel symptoms, no cognitive or any behavioral symptoms, no past history of seizure, no history of radicular pain or fasciculations, no weight loss, dry eyes, mouth, or rashes, arthalgia, or any skin changes. Skin changes means any skin rash, skin color changes history is there. In examination, we found, but history-wise it was not there. No postural giddiness, no sweating abnormalities, photosensitivity or hair loss, no history of cough, hemoptysis, melena, no history of any ototoxic drug intake. She is a hypertensive detected at age of 30 years, 36 years on medication, well controlled. Not a known patient of diabetes mellitus or no other existing cardiac conditions. She takes mixed diet with 2 to 3 servings of meat per week, no addictions or any high risk behavior, sleep is normal, bowel, bladder and appetite is normal. Regarding menstrual history, she achieved menarche at age around 11 to 12 years, menstrual cycle of 30 plus minus 5 days, duration of 5 to 7 days, not associated with passage of any clots or any pain, gravida 2, parity 2, living issue 2, no history of abortions. Last childbirth 16 years back. First day of last menstrual period, 15 days back. She practiced barrier method of contraception. Regarding treatment history, she was evaluated in 2010. She underwent triple biopsy, but it was not of any diagnostic yield. She received methylprednisolone pulse followed by oral steroids for 2 years with no remarkable improvement. 2 to 3 years back, received carnitine and coenzyme Q for 8 to 10 months with no improvement in existing symptoms. She takes antihypertensive amlodipine 5 mg once in a day since 8 to 10 years. In July 2020, patient consumed indigenous medicinal substances for 3 days. Documents was not available, but the description was honey mixed with some powder. This treatment intake was not due to any worsening of existing symptoms. She received this medication on suggestions of neighbors. Regarding family history, so this is a patient. Patient had started hearing impairment at the age of 20 years. Her sister, younger sister, is having hearing impairment at the age of 18 to 20 years. Their maternal grandmother had history of hearing impairment, started during her adolescent, and she is having 2 children. Both are asymptomatic, and there is no consanguinity in 3-generation family tree. Regarding birth history, it was a home delivery at term. Antenatal, perinatal, and postnatal periods were uneventful. All spheres of development achieved normally as compared to peers of same age and sex. Socioeconomic status, upper middle, modified Kuposome scale 16 to 25. Housing, Pakka house, good ventilation, easy water source, and hygienic practice. So to summarize, a 42-year-old lady presented with hearing loss of 25 years duration and insidious onset, stiffness, and ataxia, which worsened during DIRC in both lower limbs, which was self-limiting 10 years back, with recent acute worsening of lower limb symptoms and recent appearance of weakness and ataxia of both upper limbs, along with bulbar symptoms, with positive family history of hearing loss in sister and maternal grandmother. Here I would like to give the monitor to Dr. Abhishek Goel to analyze the symptoms.
Yeah, Dr. Abhishek is final year resident. He will analyze. Yeah, Abhishek, please go ahead.
I'm not able to share the screen. Can you?
Shall I stop here? Okay.
Yes. Good evening, one and all. So we'll start with the localization of hearing loss. As we can see here, the pathway starts from the 8th nerve and via the internal acoustic meatus, the pathway, the electrical impulses travel in the brainstem contralaterally via the trapezoid body, which is the ventral acoustic stria, and the intermediate acoustic stria, and the dorsal acoustic stria. Following that, the pathway ascends contralaterally through the lateral lemniscus, and ipsilaterally also some pathway ascends, but majority is contralaterally. And there it synapses at the inferior colliculus, and via the brachium of the inferior colliculus, it travels to the auditory cortex in the transverse temporal gyrus. As we can see here, the pathway is unilateral in outside the brainstem, and in the brainstem, it is bilaterally to the cortex. So the localization of hearing impairment, as we can see here, uh, first localization will be the conductive hearing loss, and which is at the level of external ear, tympanic membrane, or middle ear abnormalities. Then there are two things: neural and sensory, also known as sensory neural hearing loss. Neural hearing loss is the retrocochlear, most prominent for high frequency tones, that is E vowels. That are more difficult than the A, U, and O vowels. The common causes for retrocochlear hearing loss includes infections, aminoglycoside antibiotic high dose, cerebellopontine ankle tumors, etc. And the sensory hearing loss, that is the cochlear hearing loss. The causes of it includes aminoglycosides, loop diuretics, and SAFEs. And this cochlear hearing loss is typical. That is, if the inner end of the spiral is affected, then lower frequencies will be affected. And at the outer end of the spiral, there will be higher frequency affected. Brainstem requires bilateral damage as there is binaural representation, and cortex. Uh, because of the means cortical hearing loss occurs due to damage to the superior temporal gyrus. Even the bilateral damage doesn't cause complete hearing loss, and resolution will be by plasticity over time. So even with bilateral hearing loss, there are chances that the hearing impairment will improve over time, and it is classically associated with auditory hallucination in case of an irritative lesion. As we can see here, the lower frequencies are represented at the apex, and as we go out, the higher frequencies are represented at the base of the trunk. Next symptom will be the dragging of the lower limbs. It can be because of either it can be because of a foot drop, that is the element lesion. In case of foot drop, if the patient is observant, they will give a history, or the attender who is observant, they will give the history that the toe of the foot touches first, followed by the heel. And there is a classical high steppage gait because they need to clear the entire foot before going for the next stride. That is characteristic of element lesion. And in case of element lesion, that is a pyramidal tract movement, there will be associated spasticity, as is the case with our patient. There will be a history of clonus, and there will be characteristic posture attained by the patient, as everyone who has seen a patient of a chronic stroke knows that the anti-gravity muscles are affected because they are the more powerful muscles. And since in the premotor, in the pre-central area, the motor homunculus, the fine, the distal upper limb is more represented than the proximal limb. So fine motor activities like piano key movements and other like writing, etc., will be affected. So subtle UML signs can be detected by asking about the piano key movements and his fine motor activities. In our case, it is associated with spasticity. There is sequential involvement, that is right followed by the left. It is restricted to the lower limbs initially, and the patient was unable to fold the legs, that is hip flexion was affected. So even if we consider it having a spinal level, then the uppermost will be at the level of L1. So currently we can localize this structure to pyramidal tract. History of imbalance. There can be many reasons for imbalance. Whether the patient is having vestibular dysfunction, there will be rotating sensation of the environment associated with nausea, vomiting, severe imbalance. Imbalance is out of proportion to the other signs which we can elicit on examination. Then there will be positional vertigo. It can point towards a BPPV. cerebellum. That can be an axial or appendicular ataxia associated with it, and the base will be classically wide based. The gait will be classically wide based. Then there is a frontal lobe ataxia. In this, there will be classically, it will be associated with hesitancy. That is, gait ignition failure will be there. Our patient is having aggravation of imbalance in the dark, and there is difficulty in navigating in the narrow passages. It was associated with slippage of chappals without awareness, and there was cotton wool sensation while walking on the floor. So it is in our case, the structures involved will be, it can be dorsal column, dorsal root ganglia, or it can be sensory neuropathy. Next symptom, the patient had difficulty in closing the eyes. Even in sleep, she had opening the eyes open, and the shampoo used to go into the eyes, and like that the symptoms were there. So there is a facial paralysis. It can be because of two things: upper motor lesion, upper motor neuron lesion, and lower motor neuron lesion. So in upper motor neuron lesion, there will be sparing of frontalis and orbicularis oculi muscles. And in some cases, there will be voluntary emotional dissociation. And, there will,
Abhishek?
yes, sir.
Yeah, any electrical disturbance is there in your room?
Now, sir.
Yeah, no, it's not. Proceed. No, there is something.
So in upper motor neuron lesion, there is sparing of frontalis and orbicularis oculi muscles. There can be voluntary emotional dissociation. That is, if there is emotional sparing, when the patient is feeling like laughing, genuinely feeling like laughing or crying, then the facial muscle movement will be present and can be seen. So it can be because of the corticobulbar pathway interruption. And conversely, if there is only emotional facial paralysis, that is also known as mimetic facial paralysis, volitionally he is able to move the face. But however, when he is having a genuine laughter or crying crying need, the patient will not be able to move. So it is very difficult to elicit from history, and it occurs in lesions anterior to the right precentral valgus. So next we'll go to LMN. It can be because of nuclear or fascicular lesion. There will be hemifacial weakness, and even subtle LMN weakness can be localized, can be seen just by looking at the eye blink asymmetry.
So in this patient, what do you think? You have to tell that. You have told the many options or many possibilities, but in the previous slide, can you highlight in this patient what is your possibility based on the symptoms that were told to you?
It looks more like of a LMN lesion. That is bilateral. It can be nuclear or the nerve root lesion.
Mm-hmm.
Because there was a difficulty in closure of the eyes. That is orbicularis oculi weakness is there in this patient.
So, okay, proceed.
There can be dysarthria. So, myopathy classification classifies the dysarthria in many subtypes. Spastic dysarthria, that is, that occurs in UMN lesion. There will be slow, strained speech with the consonant imprecision. There will be flaccid dysarthria occurs in LMN lesion. It can be seen in brainstem and brainstem lesions and myasthenia gravis. The patient will be having a breathy nasal quality of the voice. Ataxic dysarthria occurs in cerebellum lesions, that is excessive stresses and irregular breakdowns. Hyperkinetic dysarthria occurs in the dystonia and Huntington's disease. It resembles chorea, that is marked variation in the rate, timing, loudness with sudden stoppages. There can be hypokinetic dysarthria, and the speech resembles that of a Parkinson's disease speech, low volume monotony, and it can be mixed. In this case, there was hoarseness of voice with some baby quality to it. So it can be spastic flaccid, uh, that is like mixed dysarthria. The patient also had swallowing difficulty. Like it can be classified into three based on the history. That is oral dysfunction. The patient will be having difficulty in initiating a swallow associated with drooling and food spillage, sialorrhea. There can be pharyngeal dysfunction also, and pharyngeal dysfunction also. Food getting stuck immediately upon swallowing, post-nasal regurgitation will be there, and coughing or choking sensation. And
Abhishek, just to interrupt, Abhishek, do you have that electrical connection in your computer?
no, sir, it is dissociated, detached.
I'm not sure why. It is
Sir, is some any background in the, I don't know, but it's a background sound is a
no, it's not background. It is electrical. Because it is very periodic. So maybe I'm not sure. Okay, proceed, Abhishek.
There can be esophageal dysfunction, that is discomfort several seconds after the initiation of the swallow. In our case, it looks more likely of more like pharyngeal dysfunction because she does not give any history of initiating the difficulty initiating the swallow, and also there is no history of suggestive of discomfort after after she has swallowed the food. As we can see here, this is a swallowing pathway.
What you do is you tell the possibility in this patient. So
Okay.
in this pathway, pertaining to this patient, you have to tell. You can enumerate, but quickly go to the place where you localize based on the presentation by him. Huh?
Okay. So I would like to localize in this pathway to the brainstem in this patient because there is there will be difficulty in coordination of the pharyngeal muscles and other associated symptoms of brainstem like facial nerve involvement and dysarthria. All those things are there. So I would like to localize to brainstem. So structures involved in these patients are bilateral 7th, 8th, 9th, 10th, 12th nerves will be there. Then pyramidal tract involvement we can localize it to. Dorsal root ganglia, dorsal column, either of these things, and peripheral nerves in this patient. So in view of the above mentioned symptoms and the history, the possibilities can be considered that of neurodegenerative because it is a long-standing progressive course with lack of steroid response. It is also with familial history. So heredoneurodegenerative diseases we can consider, and it is symmetrical. Because of multi-axial involvement of CNS, mitochondrial can be kept as a possibility. Other disorders like inflammatory, metabolic, toxic, nutritional, they are initially it was a remote possibility, but however because of the recent worsening in form of upper limb weakness and new brainstem syndromes, we can consider an acute on chronic etiology, that is inflammatory or infective on chronic neurodegenerative process.
Nitish, you can cross question him on this.
Yeah, Abhishek, in him, what did you think? What was the type of dysarthria the patient had?
I think the patient had a mixed dysarthria.
Which were the components involved in that type of dysarthria?
The patient had harsh speech and some breathy quality to the speech.
Okay, so
spastic plus flaccid dysarthria we can consider in this patient. So UMN plus LMN, both the components will be there. So mixed dysarthria.
But in the presence of you heard about the facial weakness, no? And
Yes, sir.
swallowing difficulty. So predominantly, don't you think it was flaccid type?
It was predominantly flaccid.
Because whenever there is a mixed dysarthria, when you approach such patients with predominantly complaint of dysphagia and other findings or other history suggestive of a particular system or neuraxis involvement, then you have to consider the predominant part. For example, ataxic dysarthria. So it may be multiple, for example, cerebellum may be involved, pyramidal also may, but predominantly sometimes you get a particular pattern. Obviously, this is just we are analyzing the history. So we would just confirm all these things when we are going to see the videos of the patient speaking. Nitish, do you have any other?
no, sir. I think we can go at the examination.
I think one person has asked about analyzing the auditory symptoms and history related to it. So resulting from auditory neurons, yeah. So this is another aspect. Actually, I thought I will go there later. That about the presynaptic and postsynaptic dysfunction. So can you just briefly tell these things because you quickly told?
Dr. Ravi, we will have all the questions at the end of the
Fine, sir. Fine, sir. Otherwise, we'll get you there.
That will be better because otherwise we lose the track of the case.
Right. Okay. We'll go to then Nitish. Should we proceed to the examination part?
Yes, sir. We should proceed to the examination part.
Okay. So Shamim, you can start the examination slides.
So our patient is an average build, alert conscious, pulse 78 beats per minute, regular, normal volume, no delay, no disparity among peripheral pulses, and condition of the arterial wall is just palpable. Blood pressure 130 systolic, diastolic 76 millimeter of mercury, supine, right hand, at rest. Pallor, cyanosis, clubbing, icterus, edema, lymph nodes, not there. Neck vein not engorged. Thyroid neither visible nor palpable. Respiratory rate 18 per minute. Chest bilateral normal vesicular breath sound heard with no adventitious sound. Cardiovascular examination S1 S2 audible with no murmur. Per abdomen normal, clinically no organomegaly. Gastrointestinal system normal. Non-syndromic facies. Skin head to feet. Extremities are of normal color and temperature. No trophic ulcers. Hair and nails over extremities are normal. No lipoma, but hyperpigmented knuckles are there. Here we can see hyperpigmented knuckles. Regarding neurological examination, MMC of 28 out of 28. Speech, hoarseness with nasal twang, straining and strangle quality. To listen to the speech, Okay. So uh, linguals, labials and gutturals affected, olfactory normal, visual acuity, right side 6 by 18, left side 6 by 24, no improvement with pinhole, fundus, bilateral pale disc with sharp margin. Regarding eye movement examination,
It is not very clear because I think of HD quality. What were the findings you can say?
yes sir. So fixation, saccades, vergence and O'Kane was normal, but pursuits were broken with engaged nystagmus bilaterally. Normal facial sensation, bilateral weakness of buccinator, orbicularis oculi, orbicularis oryx and frontalis. No facial atrophy, taste sensation was normal. Regarding hearing assessment, Rinne's test, ear conduction more than bone conduction bilaterally, Weber's not lateralized, absolute bone conduction, hearing is better in the examiner's ear bilaterally, Schaubeck test, reduced bilaterally in comparison to examiner, Bing test, mild improvement in hearing bilaterally when meatus is occluded. And hearing handicap inventory in the elderly screening questionnaire was applied and she was found to
I
have.
think you skipped this. This is not done in the routine.
Okay. So she had poor palatal elevation, gag reflex was sluggish, atrophic tongue with slow movements. Beginning motor examination, wasting of bilateral thinner, hypothinner and FTI, hypotonia in all limbs. Beginning power, shoulder uh, flexion extension 4, abduction adduction 3 bilaterally, elbow both the movements 4 bilaterally, wrist normal, small muscles are weak, hip all the groups 3 by 5 bilaterally, knee flexion extension 4 bilaterally, ankle normal. Regarding sensory examination, perception of 10% sensation to pinprick up to ankle bilaterally, 40 to 50% sensation to pinprick up to lower two-thirds of leg, sensation in the upper limb preserved, joint position impaired up to bilateral ankle and impaired up to bilateral wrist. Vibration 12 in right side and 14 seconds in left side at radial styloid, 6 bilaterally in medial malleolus, 9 seconds bilaterally at tibial tuberosity. Pseudoacidosis is present. Rombergs could not be tested because patient was not able to stand. Deep tendon reflexes. She had global areflexia, plantar, bilateral equivocal response. Gait could not be assessed. Cerebellar signs, all were normal.
Eye open, and like this. Eye closed.
This is the tongue. That's it.
So in that video, what were you trying to show? Can you speak in a few sentences? Because it was not very, it was very shaky.
Okay, sir.
Are you
So
sharing with the customer for Zoom? It is okay, na? You have an option to share the video in that format so that it is plays well.
okay,
You have shared in that way, or you have?
video is not coming well, sir.
Yeah, it is in. Anyway, you tell the findings now.
So
Because
whenever she is sitting, normally I open also mild anesthesia is there, but whenever we're asking to close the eyes, that time she is so unsteady that she is falling while sitting only. Here you can see normally she is able to sit, but after closing the eyes, she is becoming unsteady.
okay. And here?
Now regarding investigations and these things.
Now I think Dr. Abhishek can summarize all the clinical findings that Shamim has got, and maybe based on that, whether you are able to localize further and final localization we will be able to do, and then come out with the differentials.
Okay, sir. Samim, please stop sharing.
Okay.
So we can revisit our structures involved in this case. The patient, on examination, we found fundus failure, so and a low visual acuity. So we can localize to optic nerve involvement. Then there will be bilateral 7th, 8th, 9th, 10th, and 12th nerve involvement, and pyramidal tract involvement. That is distal upper limb weakness, and with lower limb involvement, and with spasticity. The patient is having prominent Romberg sign. So it can be dorsal root ganglia as well as a dorsal column or dorsal column involvement. The patient is also having broken pursuits. So it can be a cerebellum involvement also. This is a pathway for broken pursuits. So here we can localize the lesion to multiple areas. However, in this case, since cerebellum is located along with the abducent nerve complex in the cerebellopontine region, so we can localize it to that area. Based on this, we can go ahead in etiology. So patient is having sensorineural hearing loss with the lower cranial nerve involvement and upper motor neuron with the lower motor neuron involvement, along with family history with the skipping of generation. So it can be BVVL, that is Brown-Violetta 1 Loris syndrome. It can also be Faziolonde disease, that is again along the same spectrum, which is a riboflavin transport deficiency, and it is correctable by riboflavin supplementation. Then second possibility will be Baltzhauser syndrome, that is distal muscular atrophy with vocal cord paralysis, sensory hearing loss, as well as it is autosomal dominantly inherited. The points against this case is a prominent pyramidal tract involvement according to the history. However, in the examination wise, it is against the pyramidal tract environment, because the patient is having hypotonia as well as areflexia, global areflexia. Third possibility will be Madras MND. However, the patient is having a prominent sensory symptoms also in the form of rhombergism. So that is a case against this. Another fourth candidate will be a mitochondrial disorder because of multi-axial environment of nervous system, including CNS, PNS.
Okay, sir. Thank you, Abhishek, for this differentials. And then maybe I'll just quickly go through the approach to all the symptoms, the major symptomatology which our patient presented with, and then I'll go through how to approach each and every symptom, and then to arrive at a diagnosis. So Abhishek, you can stop sharing the screen. I'll start sharing the screen. Yeah, are you able to see the screen?
Make it full screen.
Yes, sir.
Yeah.
Okay. So the major symptoms that our patient had was, one was a long-standing hearing impairment, which was bilateral, and according to the history as well as the examination, it was more looking like a sensorineural hearing loss. So,
Sir, sorry to interrupt, sir. Sir, there is a play button at the top. If you do that, it will come as a full screen, sir.
okay. Is it okay?
Yes, sir. Much better. Thank you, sir. Sorry.
Yeah. So when you come across a patient with hearing impairment in association with neurological disorders, so it becomes very important to determine the nature of hearing impairment and the cause of hearing impairment, as there are many neurological disorders which are associated with hearing impairment. So first thing is, you have to ascertain whether the hearing impairment started unilateral, or it persists to be unilateral, or it is bilateral, and the mode of onset, whether it is sudden in onset or insidious in onset, progressive versus non-progressive, and what are the characteristics of hearing impairment. Like sensorineural hearing impairment, usually they have because all these impulses, the sounds that travel to the acoustic nerves are tonotopically arranged in the nerve, as well as in the nerve fibers, in the cochlear nuclei, and also in the thalamus and in the auditory cortex. So there are some patients with sensorineural hearing loss involvement due to cochlear nerve involvement, or either in the brainstem involvement, they will have pure tone deficits will be there. So this, so you will have to ask whether the patient has any impairment of speech discrimination, or these patients will have more impairment in differentiating speech in noisy places. So these are the characteristics of hearing impairment in patients with sensorineural hearing loss, so which you should look into. And you have to ask for any positive family history of hearing impairment. So many of the genetic disorders, either syndromic or non-syndromic, they will have history of hearing impairment, like patients with Alport syndrome, Pendred syndrome, Tischer-Collins syndrome, and other Wallenberg syndrome. So these are the familial syndromes which are associated with either multi-system involvement or neurological involvement. So a family history of hearing impairment should be taken. And even in mitochondrial disorders also, you will come across patients with positive family history. And then any history of medications that the patient has used. Some of the drugs like aminoglycosides, quinolones, then loop diuretics, NSAIDs are known to cause hearing impairment, which could be bilateral. And you should ask either in history and in examination also. You should try to find out if there are any associated neurological disorders, associated sensory hearing loss, which will help in coming to a diagnosis, or at least a diagnostic possibility can be arrived at. Okay, so then the first thing is whether it is unilateral versus bilateral. So again, in unilateral, whether it is acute onset or acute if it is bilateral. So acute onset unilateral, most common cause are the vascular causes like cochlear ischemia or anterior inferior cerebral artery infarction. Sometimes infections can come acutely, like tuberculosis, Lyme disease, syphilis, brucella. Brucella is very, we see a lot of patients of brucella in our state, predominantly in the North Karnataka, wherein these patients present as tubercular meningitis, and have in addition sensory or hearing impairment. So brucella comes into a differential diagnosis of tuberculosis. Other acute onset unilateral causes are common ones are trauma, Meniere's disease, and labyrinthitis. And when it is bilateral acute, it is most commonly it is because of drugs and infections, either TB, syphilis, Lyme disease, and brucellosis. And if it is chronic unilateral, then you should think of schwannoma, meningioma, syphilis, or Meniere's disease. And if it is chronic bilateral, it is usually genetic. Either it could be syndromic or non-syndromic. 80% of the prelingual patients, in patients who have not attained language or speech, the 80% is due to genetic causes. So genetic remains the important cause in these patients, the syndromic or non-syndromic, and mitochondrial could be either syndromic or non-syndromic. And metabolic such as mucopolysaccharidosis, Refsum's disease, autoimmune conditions, syphilis, Meniere's disease, and Paget's disease. So this is how asking the mode of onset and unilateral versus bilateral helps in making a diagnosis. Then the second symptom that the patient had was the weakness. So
excuse me, I just wanted to add one thing.
Yes, sir.
In our days, they used to tell that whenever you have an acute hearing loss, always rule out whether it is luteus or lupus or Lyme. This is used to be these three things are, they normally say as senior physicians in those days teaching, it is either luteus or lupus or Lyme.
Yes.
So for the students to remember. Thank you. Go ahead. Continue, please.
So whenever you come across a patient with of weakness, so again, it comes to either the mode of onset, whether it is acute or it is insidious in onset, it is unilateral, it is bilateral, and whether it is proximal more or distal more, and whether then in the history you have to ascertain whether the picture is of a UMN type or of an LMN type. So UMN patients usually have symptoms of stiffness, spasticity. Some patients give history of clonus also, and they will have a particular posture. The attitude of the limb will help in making suggests that the patient has UMN type of lesion. Like it will be the anti-gravity muscles are most affected in these patients. Wherein in patients with LMN type of weakness, you will have more of wasting of the muscles, fasciculations you may see, and the limbs are much more thinner. So in addition, the patient may tell that he has weakness of the limb. So many patients may not be able to tell properly. They may attribute everything to weakness. So it is your thing based on the history or examination to find out whether the patient is referring to weakness as in whether the patient has ataxia or it is the incoordination which the patient is referring to weakness. So apart from the history, this thing, if you don't find any features suggestive of weakness based on the history or examination, then you should think whether the patient has any incoordination of the limbs. So whether he has difficulty in navigating narrow passages, or he has difficulty insinuating the toes, the foot in the footwear, and any features of ataxia like sensory ataxia or cerebellar ataxia. So those are the things that you should keep in mind and approach accordingly. Then comes the history of imbalance. So these are the terms that the patient uses mainly, either it is a giddiness, dizziness, or imbalance. So patients may tell that it is, historically you may feel that the patient has vertigo, but because these are the terms that are used, and it makes confusing. It confuses the physician in arriving, like in making a proper diagnosis. So history of imbalance has to be taken. Like the patient may tell that whenever he walks, he feels imbalance or giddy, like he has difficulty in walking, he has difficulty in turning, and difficulty in navigating the narrow passages. So these all history suggests that the patient may be having cerebellar ataxia. And if the patient says that the symptoms worsen in the dark and he tends to fall in the dark, then this suggests more of a sensory ataxia. So these are the terms that the patient use, and whether it is a sensory imbalance or the cerebellar imbalance, so that is what you have to bring out in the history and in the examination also. So proper history to determine the cause of imbalance, whether it is a sensory type of imbalance or it is a cerebellar type of imbalance. And the onset, again, the onset progression has to be taken properly. And we have 4 types of imbalances. Like one is a sensory ataxia, cerebellar ataxia, vestibular ataxia, and frontal ataxia. So vestibular ataxia, patients will have either tinnitus, and they will feel as if the surroundings are rotating, and then during, it could be episodic also, and when during that period they will have imbalance while walking also, and associated with hearing impairment will be there. Frontal ataxia is another type of ataxia. It is a higher level gait disorder, wherein the patient has a type of magnetic gait or a freezing phenomena, so wherein the patient has difficulty in stepping or difficulty in turning, and then there are multiple freezing episodes. This is a feature of higher order gait dysfunction. Then our patient also had bulbar weakness. So what are the points? So whenever you come across patients with bulbar weakness, you have to differentiate whether the patient has bulbar palsy, there's element type, or it is a human type of bulbar palsy. That's a pseudobulbar palsy. So in such conditions, one is the associated features, like the whether the presence of dysarthria and what is the type of dysarthria, and the presence of dysphagia will help in telling like what may be the cause of bulbar palsy, whether it's the element type or it is a UMN type. If the patient has nasal twang to the voice, that is a soft palatal palsy, and difficulty in moving the tongue, and there is tongue atrophy and nasal regurgitation, that suggests that the patient has a type of bulbar palsy. Usually you don't find nasal regurgitation patients pseudobulbar palsy, and presence of pseudobulbar affect can is another historical evidence that the patient may be having pseudobulbar palsy. Then after taking a proper history, a detailed examination is important. When you come, the detailed examination includes both a detailed neurological examination as well as a detailed general physical examination also. So what you're going to look for in a patient who has sensorineural hearing loss and associated neurological syndromes. So these are the markers which you should look for. One is the dermal changes. So there are some diseases like Refsum's disease and Tanger's disease, wherein you can have this the dermal changes associated with sensorineural hearing loss, and you can see lipomas also. Lipomas are seen in patients with mitochondrial disorders. So, and patients with ataxia, sometimes the skeletal markers has to be looked into, like kyphoscoliosis, hammer toes, pes cavus, which can point towards presence of HMSN, hereditary motor sensory motor neuropathy, and Friedreich's ataxia, both of which may be associated with sensorineural hearing loss and ataxia, sensory ataxia. And the features that to suggest mitochondrial cytopathy, you should look for like lipomas, short neck, short stature, short hair, or alopecia. And a detailed neurological examination has to be taken. Fundus has to be examined, because fundus examination, presence of retinopathy, pigmentary retinopathy points toward genetic syndromic causes of sensorineural hearing loss with ataxia. And proper eighth nerve examination and pale fundus or optic pallor is one of the features of mitochondrial cytopathies. So hence a proper fundus examination is essential. And a detailed eighth cranial nerve examination, as Dr. Shamim told, that you have to do a proper Rinne's test, Weber's test, and if possible Schwabach's test also. And a proper bulbar examination, including the gag reflex, the jaw jerk, has to be looked for to certain whether it is element type or human type, and a detailed motor, sensory, and cerebellar examination has to be performed. So what are the genetic disorders associated with sensorineural hearing loss? So you have the syndromic ones and the non-syndromic ones. So syndromic, wherein you have most of the times family history is positive, like the Alport syndrome, Tischer-Collins syndrome, Pendred. Usher syndrome is associated with ataxia. Waardenburg syndrome is ataxia. Neurofibromatosis type 2 is another neurological condition, which is syndromic, associated with sensorineural hearing loss. And non-syndromic ones are usually autosomal recessive in inheritance. What are the mitochondrial disorders associated with sensorineural hearing loss when it comes to the neurological disorders? So the syndromic ones are the Mela's, Murph, and Kearns-Sayre syndrome, which are the neurological disorders associated with sensorineural hearing loss. And the non-syndromic ones are the multiple mitochondrial mutations have been described, but these are the non-syndromic ones. And what neurological disorders or what neurological signs you should look for when you come across a patient with sensorineural hearing loss. So when you come across sensory ataxia, you should think of Friedreich's ataxia, CMT. And when it comes to motor neuron disease, you have Madras motor neuron disease, Braun-Violette-Van Laere syndrome. And usually, as I think Abhishek told, that the Feijoa-Lambert syndrome, usually it is not associated with hearing impairment, though it has got it's a childhood onset presentation. Usually they don't have sensorineural hearing impairment, and they will have a motor neuron disease affecting the craniofacial and bulbar regions. So Braun-Violette-Van Laere syndrome is a riboflavinopathy because of riboflavin transporter mutation, wherein these patients have bulbar palsy, respiratory insufficiency, and hearing impairment. But ataxia is, sensory ataxia is, I don't think it is reported in patient behavior. And when you come across peripheral neuropathy, either CMT or Refsum's disease come into the picture. And if the patient has cerebellar ataxia, there are some scars which are associated with sensorineural hearing loss. And hypothyroidism is one which can cause sensorineural hearing loss and cerebellar ataxia. Autoimmune conditions are there. Kaposi syndrome is there. So yeah, so that's it. So these were the points I thought I should bring about. And
thanks, Nitish. You brought up the main aspects which we have to consider while evaluating this patient. We can go to quickly the investigations which were found in this patient, then we can discuss about the possibilities. And
yes. Regarding investigation, sir, the plan was
share the screen.
Yes, sir. Regarding investigation, sir, the plan was whatever investigation analyzer want, I will share. Or
okay. So, Dr. Sudhir Shah, should want any particular investigation, or should we quickly go through the slides? Dr. Lakshmi?
I think it is all up to you, boss. If you think some discussion is required for investigation.
Yes, sir.
Relevant investigations, whatever which threw light on the.
Yeah, just go to the relevant investigations, not the normal ones. Huh?
okay.
Full screen, make it full screen. Yeah.
Okay. So because in general physical examination, we found that our patient was having knuckle hyperpigmentation. So a quick look of vitamin B12 and homocysteine level, both are in a normal range. And one differential was mitochondrial. So lactate is slightly elevated. Our lab highest range is 20, so slightly elevated. And ammonia is normal range. And screening for IEM by tandem mass spectrometry is normal, negative. And MCV is 88. MCV is also normal. So hearing loss is profound. So beta was done. Beta was showing absence of all the waves in right side and left side both. And commonly performed test, pyotonodimetry, and it is showing bilateral decrease, bilateral both bone conduction and air conduction. So it's a suggestive of hearing, sensorineural hearing loss bilaterally.
In the higher frequencies, there is some difference between the right and left.
Yes, yes. But
okay.
So NCS.
Please tell the finding and proceed quickly. Huh?
Okay.
In NCS, what did you find? Dr. Samim? Was it normal?
No, sir. Axonal neuropathy was there.
Sural, I think, and snaps were absent bilaterally. Okay. Okay, proceed. Imaging. Samim, you are muted. Please tell. Dr. Shamim?
Shamim, you are muted. Unmute yourself.
Yes, sir. So neuroimaging, brain imaging was normal otherwise, and only cervical dorsal cord atrophy was there.
Any genetic workup done? Or any enzyme workup like acylcarnitine or any other?
Genetic is pending. The biopsy report did you show?
Yes, sir. Biopsy. Biopsy was done in 2010. It was showing the muscle biopsy left peroneus brevis. It was showing neurogenic atrophy with denervation and reinnervation. No evidence of mitochondrial myopathy or vasculitis. Nerve biopsy, left peroneal nerve, chronic axonopathy with minimal regeneration and secondary demyelination. And sir, acylcarnitine level and all in TMS, they commented on all these things. It was negative.
Was the lactate repeated again? Because at the initial level it was high, 29. Whether again it was repeated and.
Sir, repeat level was around 30 and 25. It was not beyond 30. 2 times it was repeated.
We are awaiting genetic report.
Yes, sir. Once she was tried on CoQ and acylcarnitine also for at least 1 year, there was no remarkable changes.
Okay. You can stop the screen sharing.
Okay.
So now it is open for discussion. That this is slightly challenging in the sense there is a long history, then there is a recent worsening of 6 months, which has brought the patient to us. So whether we should exclude that and dissociate that hearing impairment with the current problem, but in the presence of family history and the possibilities of conditions where there can be worsening in the later, sometimes many years, the patient has auditory neuropathy and then there is worsening of the neurological condition. So keeping that in mind, we presented this case, and there are certain issues that I think one of the participants have pointed out, if we go through auditory neuropathy spectrum disorder, then there are possibilities of whether the problem lies in hair cells or presynaptic or postsynaptic synaptopathies, channels which are involved there, or it is in the auditory pathway. So considering that many possibilities Dr. Nitish has already discussed, but the main thing is that in riboflavinopathies are one which have this spectrum. So our best bet as of now is that. But there is also another condition known as Kapos syndrome, where sometimes there is cerebral ataxia, areflexia, which this patient has, but this patient doesn't have classical all the cerebellar features. So that is one thing. And there multiple episodes are precipitated by fever. So that is again odd over here. But long-standing auditory neuropathy and sudden worsening has been reported in some of the patients with CAPOS. But I think riboflavinopathies
And as you rightly said, Dr. Ravi, in fact, we had, and what happened was cases which have been diagnosed as Madras motor neuron disease. Huh? Few of the young persons, they came back to us, and when we started looking at the riboflavin transporter deficiency, to our surprise, that they showed riboflavin transporter deficiency and a large dose of riboflavin. You'll be surprised. I was so surprised that one of my patients was wheelchair bound with upper motor neuron signs and lower motor neuron signs, with bilateral deafness and bulbar signs classically, was able to walk back home after a mega dose of riboflavin. We have only 10 milligram dose here available, but the dose requirement would be 10 tablets 3 times a day. But this mega dose of riboflavin, even if it's unproven cases of Brown-Von Willettau would definitely help. Riboflavinopathies should be one of your top differential in this case, whether he has got cerebellar or not, because there are cases, anecdotal cases, where the cerebellar involvement has been reported. So Brown-Von Willettau syndrome should be a part of your differential. This is one thing. And riboflavin and the they have that SLS3 by some riboflavin transporter deficiency gene. I think it is worthwhile looking at, even because since you are looking at a single genetic focus, it should not cost you more than 2,500. Non-genetic focus, you can even do by Sanger. Sanger sequencing itself will give you, if you tell the genetic fellow, he should be able to get you the, and I think this is worth doing it. That's one thing, as even Dr. Nitish was stressing on the riboflavinopathies, that riboflavinopathy, any treatable condition should be on your top of the differentials, however long duration it is. Don't worry about the duration, though. Sometimes, we learn by our mistakes. And now we are calling back most of the patients who have been diagnosed as Madras motor neuron disease to have look whether there is any cohort of this which we have missed. So this is what we are doing. It's a very excellent case for discussion, and I'm really happy, very happy. If there are any questions which has to be addressed, you can now address on them. And
any other comments? Dr. Sudhir Shah, any other comments?
As pointed out by Dr. Lakshmi, the treatable pathology should be first in mind, and all these vitamin syndromes are really worth exploring. We should have a relook, and some of them are accessible by genetic testing also. So I think our bet should be on that. In the mitochondrial group that you studied, because muscles were negative, but did you look at some other genetic material also?
Hello?
Any advanced genetic tests you have done in this case?
No, sir. It is pending, but clinical suspicion is that it could be riboflavinopathy. And why we presented this case is, one is that for the neurologist, it is important to understand the, like one of the, I think, attendees has asked for how the pure tone audiometry should be interpreted and what we can learn. So, but I think the time is too short for that, but quickly they should go back to the standard clinical examination books. That is clearly mentioned how we should interpret and how are the, he showed one graph where tonometric presentation of the cochlea is mentioned. So based on that only, you can easily understand that. And then what are otoacoustic emissions, and also, so the PTA, this is very important. Then there are other questions about what are the reasons for pigmentation in the tongue in this patient. So we are also not sure, but there was knuckle hyperpigmentation, and it would only be when we get a confirmation of diagnosis. And other things are that this after examination, optic neuropathy is one which we found, additional finding. So that is one thing which again goes in favor of possibly mitochondrial also. But again, we have to look at the genetics part. But otherwise, it is fitting into the riboflavinopathy. And one of the attendees has initially messaged me and said that it is earlier into the discussion that it is possibly BVVL. So, any other comments, sir?
Well, excellently done. In fact, one of the hyperpigmentation is also can happen with riboflavin.
Yeah.
Riboflavin can pick up all the angles of the mouth, angles of the conjunctiva, angles. The crural hyperpigmentation are well described. I don't know about the knuckles, but the hyperpigmentation on the crural area is well described in riboflavin. So anyhow, it's a wonderful case, sir. Is there any other things which you have to discuss, sir?
No, I think in the constraint of time, we will probably end here.
Yeah, 9:25. On behalf of both me and Professor Sudhir Shah, I congratulate all the presenters, Dr. Shamim, Dr. Nitish, Dr. Ravi, and the entire team for their wonderful presentation. And since we are on the verge of the new year, I would like to, first of all, I want to really document here that our entire neurology fraternity is thankful to all the young neurologists who have worked during the COVID crisis. My hearty thanks for every one of you across the country who has put their lives at risk, not only their lives, their life of their family at risk. I salute all of them on behalf of both of us, and my hearty thanks to the entire young neurology fraternity who have risen up to the level and made all of us proud. All of us, we are really proud of you, the entire young neurologists of the country. We are really, really proud of you. And secondly, and on the eve of the new year, I wish all of you an excellent, healthy, happy, and peaceful new year. And the third thing is January 29th, as usual, is our first week of the last Friday of the new year. The next thing will be, we are shifting to Bangur Institute of Neurology, West Bengal, where Dr. Bimal Kanti Rai would take up the next discussion. I hand over the mic to Professor Sudhir Shah for his kind words. Thank you.
Actually, you have already summarized everything, Dr. Lakshmi, and very kind of you for those summing up words. I would reiterate that the whole neurology fraternity is proud of the forefront young neurologists for their contribution. And I also thank all the participants of today, as well as of the last previous 5 episodes who have contributed in learning in neurology, particularly for the residents and the upcoming neurologists. I am sure, looking at the presence, people like this concept very much, and we will keep on continuing this. And we will request all the institutes to participate one by one. So we are looking forward for your affirmative answers, or you may come forward and write to us. And if you have any suggestions in the format, you may please suggest. Once again, thank Dr. Ravi Yadav, Dr. Nitish, Dr. Samim, Dr. Abhishek for today's presentation. To thank Professor Lakshmi for his wholehearted support and comments. I also want to thank once again all the delegates for their continuous involvement and their participation. At the end, I would give the mic to Mr. Arun Chadha to sum up and give his comments. And that way, I would like to thank Mr. Arun Chadha and the team in TAS for the entire effort that they are doing.
Thank you, sir. Thank you.
Thank you. Yeah.
Thank you, sir.
And Happy New Year to everybody. Stay well, stay safe. Yes, Arun bhai, go ahead.
Thank you, sir. It's really great that we are at the end of the sixth session of the Secret of Neurology. Turned out to be very successful. I, Arun Chadha, Senior General Manager, on behalf of Intas Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence. It's audience like you that make presentation awesome. Thank you very much for your unwavering attention throughout this presentation. First of all, I would like to thank our Honorable Course Director, Dr. Lakshmi Narasimhan sir, Dr. Sudhir Shah sir, for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DNB students. And I would like to thank to our young neurologist, Dr. Mohammad Sami and Dr. Abhishek sir, for presenting the case. Further to this, I would like to thank Immense Neurology Department, Dr. Ravi Yadav sir, and Dr. Nitish sir for presenting such a unique case, which is fabulous, with the fabulous presentation and which will be very extremely helpful and informative to all the participants. Once again, thank you for your gracious presence, and it's been a pleasure being with all of you. Thank you all for your patience, and I wish you all a very good night now. On the eve of the new year, I am wishing you a very happy new year 2021, and we will, with the promise that next year on 29th Jan to meet with the most awaiting next session of the Secret of Neurology. Till then, stay safe and take care. Thank you. Thank you, sir. Thank you very much.
Thank you, sir.
Thank you. Thank you, Ellie. Thank you.
Thank you. Thank you, sir.